The osteoblast makes MCSF. It also expresses rank L on its surface. The MCSF can stimulate the osteoclast. The rank L can bind to the osteoclast. And in this manner, the osteoclasts become activated and they will reabsorb bone and they will increase the amount of calcium and phosphate in the serum. A final detail about the mechanism by which parathyroid hormone affects the bones. Recall that there are two types of bone tissue. Cortical bone is the hard outer layer of bone, and this is the layer of bone that decreases in response to continuous parathyroid hormone administration. This is the layer that is reabsorbed so that calcium and phosphate levels rise in the serum. The other type of bone tissue is called trabecular bone. This is the spongy inner layer of bone, and this is the layer of bone which will increase in response to intermittent low-dose exposure to parathyroid hormone. There is another hormone produced by many cells in the body that is very similar to parathyroid hormone, and it is appropriately called parathyroid hormone-related protein. It's produced by many cells and tissues, and it's been shown to have numerous normal effects. What you need to know about this clinically is that it is synthesized in large amounts by some tumors, especially renal cell carcinoma and squamous cell lung cancer. This can lead to hypercalcemia in malignancy because parathyroid hormone-related protein exerts the same effects as parathyroid hormone, and thus it will raise the serum calcium level and cause hypercalcemia in malignancy. For the remainder of this module, I'm going to talk about disorders of the parathyroid glands, and we'll begin by talking about hyperparathyroidism, which is when the gland is overactive. And there are three forms of hyperparathyroidism. Primary hyperparathyroidism is when the gland itself is simply overactive. Secondary hyperparathyroidism is when the parathyroids are overactive due to persistent hypocalcemia. And then finally, tertiary is an unusual type of hyperparathyroidism seen in renal failure. Primary hyperparathyroidism is inappropriate secretion of parathyroid hormone, and the word inappropriate is very important. That means that the parathyroid gland is releasing parathyroid hormone not because of low calcium. This is commonly caused by a parathyroid adenoma, which is a portion of the gland that has begun functioning autonomously and is secreting parathyroid hormone on its own without being responsive to the level of calcium in the serum. The result of the excess secretion of parathyroid hormone will be hypercalcemia. You will see increased renal reabsorption of calcium, increased vitamin D activation, and you will see increased resorption of bone, that cortical portion of the bone we talked about before. You will also see more phosphate going out in the urine, and all of these are normal effects of parathyroid hormone, but in primary hyperparathyroidism, they are occurring not due to a low calcium, they are occurring due to autonomous function of a portion of the parathyroid glands. And at the bottom of the screen, I've written what you see on serum testing in primary hyperparathyroidism. You see an increased level of parathyroid hormone and a high calcium, and this should never be the case under normal circumstances. Parathyroid hormone should only be elevated when the calcium level is low. However, in primary hyperparathyroidism, you have increased parathyroid hormone in the setting of high calcium. That is backwards, and that tells you something is abnormal. Let me make an important point about the urinary calcium level in primary hyperparathyroidism. The urinary calcium level is usually high or normal, and this can be confusing as a medical student. The high parathyroid hormone level leads to increased urinary reabsorption of calcium, and as you know, this is one of the mechanisms that leads to hypercalcemia. This can lead you to believe that the urinary calcium level should be low, but that is incorrect because there's another fact you need to appreciate. The hypercalcemia leads to more calcium being filtered, and this overwhelms the reabsorptive capacity of the nephron, and this leads to a rise in urinary calcium such that the urinary calcium level becomes normal or high. It is not low in primary hyperparathyroidism, and make sure you understand that mechanism. The symptoms of primary hyperparathyroidism are the symptoms of hypercalcemia, and those symptoms go by the mnemonic stones, bones, groans, and psychiatric overtones. Now, in reality, this is largely historical. Years ago, when there were no treatments for hyperparathyroidism, patients would have calcium levels that would climb and climb and climb until they developed all of these symptoms. In the modern era, most patients are diagnosed early in the course of their disease. In fact, most patients who are diagnosed are asymptomatic. Many primary care physicians check calcium levels annually on routine blood work, and they often make the diagnosis when the calcium level is elevated. Another common presentation in the modern era is recurrent kidney stones. Some forms of kidney stones contain calcium, and when you have mild hypercalcemia, one of the first things that can happen is you get kidney stones recurrently. The other signs and symptoms like stones, bones, groans, and overtones, when they are seen, are often seen in the setting of malignancy. Hypercalcemia malignancy can occur much more rapidly than hypercalcemia from primary hyperparathyroidism, and thus patients can quickly develop a high calcium level, and you will sometimes see all of these symptoms. So let's talk in more detail about the symptoms you can see in hypercalcemia and in primary hyperparathyroidism. As I said before, you can develop kidney stones. This is from high calcium in the urine causing kidney stones. You can also see dehydration in hypercalcemia. This occurs because calcium blunts the effects of antidiuretic hormone. This causes a picture that looks like nephrogenic diabetes insipidus with polyuria and polydipsia, and if it's severe, it can lead to renal failure. Bones refers to the bone pain that can occur in hyperparathyroidism. This is the result of the adverse effect on bones of long-standing high parathyroid hormone, and we'll talk more about that in a minute. Crohn's stands for abdominal pain. This is for the constipation, anorexia, and nausea that patients develop when they have high levels of calcium. In addition, it's long been known that you can see increased stomach acid production in patients with hypercalcemia and hyperparathyroidism. The mechanism of this is unclear, but you should be aware that recurrent peptic ulcers is also something you can see in hypercalcemia. And then finally, if your calcium level gets very high, you can become disoriented and confused. This is psychiatric overtones. Patients with hypercalcemia can have anxiety and altered mental status from the high calcium levels. Now I want to spend a minute talking about the bony changes that occur in hyperparathyroidism. Those changes are called osteitis fibrosis cystica. This is the classic bone disease seen in long-standing untreated hyperparathyroidism. The clinical features that develop and what the patient will complain about are bone pains and recurrent fractures. What's happening at the tissue level is that bone is being resorbed in the subperiosteum. You should remember this word subperiosteal. It's a USMLE buzzword. Recall that the periosteum is the membrane surrounding bone, and just below that layer, bone resorption occurs in hyperparathyroidism. This is commonly detected on x-rays in the bones, and in the fingers you will see irregular or indented edges to the bones, and that's because those edges just below the periosteum are being resorbed. The other classic finding of osteitis fibrosis cystica is called brown tumors. These are also sometimes called osteoclastomas.